Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome along to the Surgical Edge podcast. If you're with us, you know we aim to give you that rapid, usable intelligence. And today, we're doing a pretty critical deep dive. We're looking at perrectal bleeding or lower gastrointestinal bleeding, LGIB. It's one of those really common acute presentations that can, turn serious fast.
Absolutely. And our focus today is really quite specific. We want to pull out the objective, validated tools from the British and European guidelines, the kind of tools that help us move beyond just, gut feeling. They allow for that quick risk check, better use of resources, and hopefully, better outcomes for patients.
Okay, but before we dive right in, the usual crucial reminder, this is the Surgical Edge podcast, and this content, it's for reference. Always follow your local hospital guidelines and protocols in actual clinical practice.
Couldn't agree more. We're here to unpack the evidence. Specifically, we're focusing on two, let's call them non-negotiable tools for LGIB, the shock index and the Oakland Score. These are the things that really replace asking, how sick do they look with, hard data?
Right. Let's start at the beginning then. Initial assessment. When that patient comes in with PR bleeding, what bits of the history immediately make you think, okay, higher risk here, even if they initially seem okay?
Yeah, the history needs to be targeted right away. You need to focus on the things that really drive up the risk. So beyond the usual questions about volume and frequency of the bleeding, you got to ask about key comorbidities like liver disease, recent surgery, especially abdominal. And critically, are they on anticoagulants, antiplatelets? These things really complicate the picture and feed straight into those risk scores we mentioned.
Okay. And diagnostics. What labs are absolutely essential right at the start before we even think about where this patient is going? Because these numbers feed the algorithms, don't they?
They do. You need that full picture of their stability and the systemic impact. So that means a full blood count, obviously. Urea, creatinine, CRP, LFTs are important too. Clotting screen is essential. And given how quickly things can change, get that cross-matched blood sorted immediately. The hemoglobin level itself is, it's a core part of the scoring. Non-negotiable.
Yeah, right. Makes sense. Okay. Differential diagnosis. There's a long list, but let's maybe simplify. What are the top 3 categories, say, that every clinician needs to have front of mind? And what's the key difference between them clinically?
Good way to frame it. You need to think about the common, the severe, and the chronic concerns almost immediately. So first, diverticulosis. It's the most common cause of severe LGIB. The key thing, it's often massive bleeding, but painless. That's the flag. Needs quick resuscitation.
Painless but massive. Okay. Number 2.
Second, angiodysplasia. You see this more in older patients. It tends to cause recurrent, maybe lower volume bleeds. It's down to these vascular malformations.
Okay. Recurrent, often in the elderly. And the third, the one we really can't miss.
That's colorectal carcinoma. It can bleed acutely, sure, but often it's more insidious. Chronic blood loss. Patient presents with iron deficiency anemia. That's a very different pattern.
That distinction, painless massive bleed versus chronic anemia, that's a really key clinical pivot point, isn't it? So, okay, we've got our history clues, we've sent the labs, now the crunch point, limited beds, limited resources. How do we objectively decide who's safe to potentially go home versus who's really sick and needs admission right now? This is where the scores come in.
Exactly. Relying purely on clinical impression, it leads to problems both ways. You admit people who maybe didn't need it, wasting resources. Or worse, you send someone home who's actually high risk and they come back worse. These scores help avoid that guesswork.
Let's break them down. Tool 1, the shock index, or SI. Calculation seems almost too simple. Heart rate divided by systolic blood pressure. But the guidelines stress how powerful it is for predicting bad outcomes.
It is incredibly simple. HR over SBP. But what's really clever about it is how well that simple ratio picks up on hidden or impending shock. You might miss it just looking at BP or heart rate alone. The blood pressure might still be technically normal.
But the heart's working overtime to keep it there.
Precisely. The heart rate is disproportionately high for that BP. The ratio flags that underlying instability.
So what's the number, the threshold we need to remember?
The critical cutoff is SI greater than 0.7. If it hits 0.7 or goes above, the evidence is clear. The patient has a high risk of severe bleeding, needing blood, and generally having a poor outcome. It's more than just a flag. It really demands urgent action, even if other vital signs seem okay initially.
Okay, SI 0.7 is the immediate danger signal. Got it.
Now, tool 2, the Oakland Score. This feels a bit more involved than the SI. For a clinician under pressure, calculating a score with, 7 parts? Does that feel like a barrier sometimes? It is more comprehensive, yeah, because it's really designed for that disposition decision, safe discharge or admit. It pulls together 7 key bits of data: age, gender, heart rate, SBP, hemoglobin level, findings on the rectal exam, and crucially, a history of ischemic heart disease, or IHD.
And you mentioned IHD is crucial. Is that the part that sometimes gets missed in the heat of the moment?
I think it can be, yes.
Yeah.
It's easy to focus on the current vitals, the HP. But that history of IHD is vital. A patient with heart disease just has less physiological reserve, doesn't tolerate blood loss as well. The score correctly weights that increased risk even if they seem stable when you first see them.
That makes sense. It's about underlying resilience, not just the snapshot. So the Oakland Score thresholds, what are the numbers the guidelines tell us to use?
Okay, so it stratifies risk quite neatly. If the score is less than or equal to 8, so 80 line of 21, that patient is classed as low risk. They are potentially a candidate for safe discharge, provided you've reasonably ruled out anything sinister, of course.
And if it's higher?
If the score is greater than 8, that's your high-risk flag. For these patients, admission is mandatory. They need observation in hospital, and you need to start planning interventions quickly.
Right. This is where it gets really practical. We've got 2 objective scores. Let's take a scenario. A patient scores 6 on the Oakland. Technically low risk, suggests discharge maybe. But UT, their shock index is 0.8. High risk suggests they could crash. How do the guidelines tell us to handle that clash? Which score wins?
That's a really important practical point. When they clash like that, the shock index generally dictates the immediate management. Think of the SI as your immediate physiological fire alarm. If that SI is over 0.7, it doesn't matter if the Oakland score looks reassuring for the longer term. That patient needs admitting now for resuscitation and close monitoring because their immediate risk of deterioration is high.
Okay, so the SI trumps Oakland for the what do I do right now decision. You use SI for the immediate hemodynamic red flag and Oakland for the overall discharge safety assessment.
Exactly. That's the way to think about it. SI for urgency, Oakland for disposition safety.
Perfect. That clarifies the priority. Let's move into the management pathway then. We've decided, based on the scores or maybe just clinical state, that the patient needs admission. Resuscitation first.
Yep, ABCs as always, but the focus shifts quickly to circulation. 2 large bore 5E lines start fluid resuscitation with isotonic crystalloid. Aim to keep them perfused. But then comes the question, when do we actually give blood?
Yeah, what are the definite triggers for transfusion according to the guidelines?
Okay, so transfusion is definitely indicated if they're actively visibly bleeding right now, or if they're clearly symptomatic from the anemia, dizzy, hypotensive, chest pain even. Or objectively, if the hemoglobin drops below that key threshold of 80 grams per liter, 80 GL.
And potentially lower, or rather a higher threshold to transfuse if they have heart disease.
Yes, exactly. For patients with known IHD or significant coronary artery disease, you might have a higher threshold, maybe transfused at HB 90 or even 100, depending on the clinical picture and local policy. And crucially, while you're resuscitating, you need ongoing monitoring. Keep checking vitals, recalculate that shock index regularly, see how they're responding.
Makes sense. Let's bring the scores back in to guide the next steps. The high-risk pathway, Oakland 8 or SI 0.7, they're admitted. What's the sequence of investigations or interventions?
Right, so they're in. The priority is finding and stopping the bleed. The cornerstone here is early endoscopy. If the patient is stable enough, they need a flexible sigmoidoscopy, or ideally a full colonoscopy within 24 hours. This isn't just for diagnosis. Often therapeutic intervention, like clipping or injection, can happen at the same time.
But what if the scope can't find it or the bleeding's too heavy to see properly? Then we move to imaging.
Correct. If endoscopy fails or isn't feasible, or the bleeding is just too fast and furious, the next step is usually CT angiography. This can pinpoint the active bleeding site by showing contrast leaking out of a vessel. It's really key before calling interventional radiology.
And that leads us to embolization, which seems to be avoiding surgery more and more.
It really has been a game changer. If the CT angio shows an active bleeding point, then transcatheter embolization by interventional radiology is often the next step. They can go in, target the specific vessel, and block it off. It's minimally invasive and highly effective, especially for things like diverticular bleeds. Often avoids a big operation.
So when does surgery actually happen these days?
Surgery is really reserved for the most severe cases. We're talking life-threatening hemorrhage that hasn't been controlled by endoscopy or embolization. If you know where the bleeding is coming from, say, CT angio localized it, but embolization failed or wasn't possible, then a targeted segmental resection might be done. But if the bleeding is catastrophic and you still don't know exactly where it's coming from despite all efforts, then the standard life-saving operation is often still a subtotal colectomy. It's a big operation, but sometimes necessary.
Got it. We definitely need to touch on coagulopathy. Patients on anticoagulants or with clotting issues, that adds a whole layer of complexity, doesn't it?
Oh, absolutely. This needs immediate attention. You have to stop the offending agent, the warfarin, the DOAC, the antiplatelet. Then you need to reverse it, balancing the bleeding risk against why they were anticoagulated in the first place. For warfarin, it's vitamin K and often PCC prothrombin complex concentrate for rapid reversal. For the DOACs, there are specific reversal agents now, and you absolutely must follow your national or local guidelines for using those. No delays here.
That clarity on reversal is so important for clinicians on the ground. Okay, let's bring it all together. We've assessed, scored, resuscitated, investigated, maybe intervened. How do we finally decide it's safe for someone to go home? What are the hard criteria?
Discharge has to be based on objective data and clear stability, not just feeling better. The patient must have that confirmed Oakland score of 80 quidals, and their shock index must be consistently 0.7. Both conditions need to be met. Plus, you need to have identified a likely benign cause or confirmed successful treatment of a severe one. And, of course, they need to be hemodynamically stable for a suitable observation period with evidence the bleeding has stopped.
It really is quite elegant how it boils down to using those two scores consistently. Oakland for the admission-discharge safety net, shock index for that immediate O factor, and resuscitation trigger.
That's the core message, really. These scores need to move off the pages of guidelines and become, well, mandatory data points documented for every patient every time. Documenting the SI on arrival, calculating the Oakland score to guide disposition that ensures decisions are evidence-based, predictable, and ultimately safer.
So that leads to a really practical thought for everyone listening. Thinking about your own unit, your own emergency department or ward, what specific system change could you put in place tomorrow or next week to make sure the shock index is calculated and documented on every single patient presenting with PR bleeding? How can you bridge that gap between the guideline recommendation and routine bedside practice?
That's the challenge, isn't it? Making it routine, a really important point to consider.
Absolutely. Well, if you found this deep dive valuable, please do think about sharing it with just one colleague or friend who might also benefit. Thank you for joining us on the Surgical Edge podcast.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.